Great, everyone. Thank you for coming today. I'm excited to introduce you guys to Cathy Shyr. She is a postdoctoral research fellow at the Vanderbilt University Medical Center, and she's here to talk to us about estimating heterogeneous treatment effects using statistical machine learning. So I'll let you take it away, Cathy, and thank you so much.
Great. Thank you so much for that very kind introduction. My name is Cathy Shyr. I'm very excited to be here today at the Hopkins Causal Seminar. Before we dive into the multi-study R-Learner, I would like to say a huge thank you to Helen Guo and Peter Liu, the student organizers, and also to Dr. Liz Stewart for the kind invitation, and also Dr. Michael Rosenblum for the warm welcome. So before we dive into the talk, I want to give everyone a quick introduction about myself and also to provide a little bit of context for this work. So I graduated with a doctorate in biostatistics from Harvard University in May 2022. This project is actually one of my dissertation research projects under the mentorship of my advisor, Dr. Giovanni Parmigiani, whom I think is actually on the call today. Hey, Giovanni. So Giovanni is a professor of biostatistics at Harvard and also at the Farber. He also serves as the associate director of population sciences at the Farber. Currently, I'm a
former faculty member here. Sorry, I'm totally interrupting, but Giovanni was also here many years ago. So
yeah.
definitely the Hopkins connection.
Full circle, yeah. So currently I'm a research fellow in the Department of Biomedical Informatics at Vanderbilt, mentored by Dr. Paul Harris. He's a professor of biomedical informatics and also the vice president for research informatics at Vanderbilt. He is the contact PI of the All of Us Research Program's Data and Research Center, which I'll talk a little bit more about in just a little bit. So my research, really the common thread is precision medicine. My K99 and R00 award focuses on developing AI and statistical machine learning methods in the context of undiagnosed rare diseases. Now, when it comes to precision medicine, I think everyone in the room and on the call are probably familiar with the maxim, medicine is not one size fits all. And I think rare disease is such a great example of where doctors have to personalize their diagnostic and treatment strategies to patients of sample size n equals 1. In addition, patients with rare disease can present with very complex and heterogeneous clinical features that make it very difficult to diagnose their condition. So my work focuses on improving rare disease diagnostic efficiency and accuracy by developing large language models trained on unstructured clinical notes from patients' electronic health records to support clinical decision-making. Now, for these patients and their families, getting an accurate diagnosis is really the first step in their journey. The next and perhaps more important step is to come up with the treatment strategy and disease management strategies for their condition. So another component of my research focuses on developing causal inference methods using data from the All of Us research program to understand how the genotypic, phenotypic, and environmental factors all come together to influence disease. So for folks on the call who may not be as familiar with the All of Us research program, it originally started as a precision medicine initiative almost 10 years ago now, back in 2015. And at the State of the Union, President Barack Obama really envisioned this program to be one of the largest and most diverse precision medicine cohorts that can revolutionize medicine. Fast forward 3 years, in May 2018, the All of Us research program officially launched and is seeking to enroll at least 1 million participants nationwide that reflect the diversity of the US. So I think what's really unique about the All of Us research program dataset is really the breadth of data types, which can range from electronic health records to genomics data, Fitbit wearables data, and also environmental health data, including social determinants of health. That, in addition to the size and the richness of the data set, really opens up a lot of opportunities to develop causal inference methods to advance precision medicine. So the question of interest is really thinking about what works best for whom. And I think the answer to that question is also going to be the focus of today's talk, which is the multi-study R-learner for estimating heterogeneous treatment effects. So I've got the title of the talk on the slide here. I want to quickly highlight two main components to really help frame this project. First is why multiple studies, and second, why heterogeneous treatment effects. Okay, so let's get started with the first bullet point, why multiple studies? So at a 30,000-foot level, I want to give everyone a quick overview of three key opportunities for estimating causal effects across multiple studies. The first opportunity is really the increased availability of large-scale multi-site data, like All of Us. So the All of Us data set contains diverse observational health information that are collected across over 50 plus healthcare provider sites in the United States. So as biobanks like All of Us, UK Biobank, and FinGen are really becoming a global trend, I think the potential utility of leveraging multi-site data is really promising for causal inference. The second opportunity is the need for evidence synthesis in public health decision-making. So this is a screenshot of an article that was published in JAMA looking at scientists pulling data from individual clinical trials during the COVID-19 pandemic. And if we look at when this article came out, July 22nd of 2020, you may remember that was actually during one of the peaks of the pandemic in the US. So I think this is a great example of how leveraging information from multiple data sets can enable timely assessment of treatment efficacy during perhaps one of the largest public health crises in the last decade. Last but not least, the third opportunity I want to highlight is really the momentum from legislative guidance on leveraging data from multiple sources. So the 21st Century's Cures Act really propelled the US FDA to provide guidance on supplementing trials with observational data. So on the bottom right of the screen, I've got a screenshot of a guidance document that came out last year from the FDA, specifically looking at the use of real-world data and real-world evidence to support regulatory decision-making for drugs and biological products. So really, in summary, the landscape is really ripe for leveraging multiple data sets to estimate causal effects. And with that, let's switch gears and talk about the second component, why heterogeneous treatment effects. So heterogeneous treatment effects, or HTEs, are central to precision medicine, where the goal is to tailor the treatment to a patient based on their unique characteristics. Now, when it comes to a patient, his or her health profile is a constellation of the different genetic, clinical, and lifestyle or exposure factors. And an HTE occurs when patients with different characteristics respond differently to the same treatment. So here I've got a plot of the treatment effect on the y-axis versus patient characteristics. The average treatment effect, which is typically reported from randomized controlled trials, is constant. On the other hand, the heterogeneous treatment effect varies as a function of the patient's characteristic. And so as a result, we can then identify subpopulations of patients who may benefit from the treatment or otherwise be vulnerable to it. So I think from a healthcare provider's point of view, the goal here is to really think about when that new patient walks into the clinic and we observe their patient characteristics, can we make use of that information to come up with the most optimal treatment decision for that patient? So to help motivate the multi-study R learner, I want to frame everything in a breast cancer example. So breast cancer is a molecularly heterogeneous disease with 4 main subtypes. And these 4 subtypes are characterized by a combination of whether the patient has HR positive or negative or HER2 positive or negative status. So these are different types of receptors in the human body. And depending on where the patient falls on this spectrum, she can have better or worse prognosis. So the question of interest is, what is the treatment effect of, let's say, chemotherapy A, so binary treatment, 1 meaning the new treatment, 0 meaning standard, on tumor size Y, given patient characteristics X. So we're thinking about age, subtype, genetic factors, etc. So one simple way to approach this is to use a linear regression model. We can estimate the treatment effect tau using ordinary least squares. And then we can report the coefficient tau hat OLS as a treatment effect estimate. So this approach is justified if 1, A is randomly assigned, as in the randomized study, or in the observational setting, A is randomized given X. So we're assuming no unmeasured confounders. Second, we're also assuming that the treatment effect tau is constant. And third, that X has a linear effect on Y. So if we pause here for a second and think about these 3 assumptions, you might think that assumption 3 is quite strong without any scientific or methodological motivation. So with that, a simple workaround is to use a partially linear model. So instead of having X beta, we now have f of X. And again, this approach is justified with the same set of assumptions as before, but now we've gotten rid of the last linearity assumption. From here, given the partially linear model, which I've written in equation 2, Robinson, in his 1988 paper, root n-consistent semi-parametric regression, observed that we can actually rewrite first by taking the conditional expectation of given X on both sides, and we're going to denote this, the mean outcome given X, as m of X on the left-hand side. And then on the right-hand side of the equation, again, we also take the conditional expectation given X. And so here, A is binary, so we have the propensity score, E of X, times tau plus f of X. And so then we can do a little bit more algebraic manipulation. We can subtract m of X from Y, and we can re-express the partially linear model as the equation that's shown in equation 3. And this is known as the Robinson's decomposition. So on the left-hand side, we have the observed outcome minus the mean outcome model. So this is the outcome residual. On the right-hand side, we have the treatment assignment minus propensity score. So this is the treatment residual times tau plus some epsilon. So with this Robinson's decomposition, we can arrive at the following 3-step approach to estimation. The first step is to estimate the propensity score E by predicting A from X. Then we can get an estimate of M by predicting Y from X. Then what we can do is plug in these estimates, and we can estimate tau, our parameter of interest, by doing residual on residual regression. So essentially what we're doing is regressing the outcome residuals on the treatment residuals to get our estimate of tau. So seems intuitive so far, right? But I think the question here is, does residual on residual regression actually work? So there are a couple of things that we need to think about. First, in practice, E and M, which are the nuisance functions, may be nonlinear and high dimensional. We can use flexible machine learning methods to estimate them. However, that may lead to the tau hat having unknown statistical properties. The second thing we need to consider is that we are estimating the nuisance functions E and M and the parameter interest tau on the same data. So there's this data reuse problem going on and the risk of overfitting. So the question is, can tau hat still attain good large sample properties under these circumstances? And the short answer is yes. So in his paper by Shyr titled Double D-Bias Machine Learning for Treatment and Structural Parameters, he showed that tau hat can still have good large sample properties given the following three key ingredients. The first ingredient is the Neyman orthogonality moment condition that is given by the residual on residual regression setup. So in a nutshell, this ensures that the moment is insensitive to local mistakes in the nuisance functions. The second key ingredient is fast enough convergence of the E hat and M hat. So this ensures that these nuisance function estimators are sufficiently accurate as n goes to infinity. Last but not least, to address the issue of data reuse, he talked about this sample splitting approach called crossfitting. So I want to give everyone a quick overview of how crossfitting works. The idea is that we could randomly split the data into two halves, the main sample and the auxiliary sample. In step 2, we can use the auxiliary sample to obtain the estimators for the nuisance functions using any off-the-shelf machine learning approach. And in step 3, we will use the main sample to estimate tau1. In step 4, we will reverse the roles of these two samples and obtain the estimator tau hat 2. And the last step is to take the average. So with that, so far, we've only focused on looking at constant treatment effects. We can extend the partially linear model for treatment effect heterogeneity. So in equation 4, we can see that instead of having tau, we now have tau of x. And in Nye and Wagger's 2021 paper in Biomedical, they propose estimating tau by optimizing the R loss. So R for Robinson's and R for residual on residual regression. So R loss, which is shown in equation 5, is looking at essentially the square error loss. And the resulting estimator tau hat is known as the R learner. So I want to briefly pause here and see if there are any questions from the audience before diving into the multi-study R learner. So far, so good.
Seems like none from the room.
Okay, great. Thank you, Helen. All right, so as I've alluded to before, with the increased availability of multiple studies, we're seeing more data sets that are looking at the same treatment and outcome. Now, when a new patient walks into the clinic, he or she did not participate on any one of the case studies. However, based on her characteristics, she is eligible for them based on her X. So I'll give everyone an example of when this could happen in practice. So an example is competing trials. So that's when either at different institutions or at the same institution that there are multiple studies looking at the same treatment and same outcome and are recruiting patients with very similar covariates X. In this case, relying on the heterogeneous treatment effect estimate from a single study may overlook valuable data from the other studies. A more comprehensive approach is to synthesize information across multiple studies. So for the multi-study R-learner, our target estimate is a weighted average of the study-specific HTEs. The weights reflect the degree of covariate overlap between the new patient and each study, and we refer to this estimate as the new patient HTE. So let's formalize this by talking about the problem setup and assumptions. So suppose we have data from capital case studies, and for patient I index from 1 to little nk in study K, we observe their outcome, Y, their p-dimensional covariate vector X, their treatment assignment A, and their study label S, where S is drawn randomly according to the membership probability. So the membership probability denoted by little pk given x is the probability of belonging to study little k given the covariate vector little x. In addition, we let y1 and y0 denote the potential outcomes that would have been observed under the treatment assignments a equals to 1 and a equals to 0, respectively. In addition to the data from patients on these case studies, suppose we also have new patients who were not part of the original case, not part of the case studies, and therefore we do not have a study label S for these patients. From these patients, we observe their covariate X, and recall that these patients meet the eligibility criteria of multiple studies. So for some little x, their membership probability is going to be positive for more than one study K, where the membership probability reflects a degree of covariate overlap between these patients and study K. So our target estimate is the new patient HTE and is denoted by tau of x. So this is looking at the mean difference in the potential outcomes conditional on x. The new patient HTE is a weighted average of the study-specific HTEs given covariates little x, and the study-specific HTEs are denoted by tau k of x. So this is essentially the same as before, but now we're conditioning on the study level S equals to K. I think my slides are freezing up a little bit. Is everyone still seeing the same slide of the target estimate?
Yes.
Okay. Just give me 1 second. Okay, there we go. All right, so we'll introduce a little bit more notation. So M of little x is the conditional mean outcome function given x. Mu 0 sub k of x is the study-specific conditional response under treatment assignment a equals to 0 given x and study k. So a more straightforward of saying it is this is really looking at the mean baseline risk given x and study little k. And last but not least, EK of x denotes the study-specific propensity score given x and study k. So when it comes to estimating the new patient HTE using information from multiple studies, a key consideration is to take into account the different sources of between study heterogeneity, which can result from differences in study populations, design, and sample characteristics. Overlooking between study heterogeneity can result in inaccurate estimates of the new patient HTE, which may lead to suboptimal treatment decisions. So I want to quickly highlight 3 types of between study heterogeneity that are commonly encountered in practice. The first is between study heterogeneity in the tau case. And this can arise from varying distributions of unobserved effect modifiers across studies. So going back to the breast cancer example, there's a lot of evidence that shows exercise level is a modifier of breast cancer treatment. So if exercise level is not routinely collected in clinic, meaning it's unobserved, and if 2 studies have different distributions of exercise levels, then tau 1 is not equal to tau k. The second source of between study heterogeneity is between study heterogeneity and the mu k zeros. This can arise again from varying distributions of unobserved covariates across studies. So exercise again would fall into this category. So it's been shown that exercise can prevent breast cancer or reduce the risk of breast cancer. And if it's unobserved and 2 studies have different distributions of exercise levels, then we might see differences in the mu k zeros between 2 studies. And last but not least, between study heterogeneity and the propensity scores, EK, can result from differences in clinical guidelines and healthcare provider practices. So being a patient at a comprehensive cancer center versus at a community clinic there might be differences in the treatment protocol where someone at a comprehensive cancer center may be more likely to be prescribed a more aggressive or newer treatment than a patient at a community clinic. So the objective of the multi-study R-learner is to estimate the new patient HTE that directly accounts for these sources of between study heterogeneity. So here are the three assumptions for identifiability. First is consistency. So this assumption says that the observed outcome is equal to the potential outcome under the treatment actually assigned. Assumption number 2 is mean unconfoundedness within study. So this says that given little x in study little k, that the mean potential outcome is unconfounded. Assumption 3 is positivity of treatment within each study. So this says that for each treatment little a and for each x in study k, that the probability of being assigned to either treatment is non-zero. Under assumptions 1 and 2, we can rewrite the conditional outcome M of x as follows. We can do a little bit of algebraic manipulation and arrive at equation number 6. And this is the multi-studies Robinson's transformation. So on the left-hand side of the equation, we see, again, this is the outcome residual. On the right-hand side, we see a weighted average of the study-specific treatment residuals, the study-specific HTE tau k, and the weights are the membership probabilities. So this is really the crux of the multi-study R-learner. From here, we can come up with the multi-study R-loss, which is shown here at the top of the screen. And we can optimize this loss, ln, to estimate tau 1 through tau k. So here, this capital lambda represents a regularizer on the complexity of tau k to reduce and mitigate overfitting. So ln represents the oracle loss function, meaning that the nuisance functions m, the EKs, and the membership probability PKs are known. In practice, that's typically not the case, so we need to estimate them from data. So these quantities can be estimated using statistical ML techniques, for example, penalized regression, deep neural net, that's appropriate for the task at hand with cross-fitting. So the loss function with these estimates plugged in is called the plug-in R-loss, multi-study R-loss, which is denoted by ln hat. So everything is the same as before. Now we've put hats on the nuisance functions and the membership probability. And again, we can optimize it to estimate tau 1 through tau k. One thing I want to point out is that if we look at this loss function, S is not explicitly represented. So again, S is the study label. However, it is implicitly incorporated in the square error term through the estimated membership probabilities, P hat K given X. So at this point, I want to quickly pause and really dig into the membership probability for a few slides. And this will give everyone more intuition as to what's really going on under the hood. So in a nutshell, the membership probability controls how much information is borrowed across studies. The higher the probability, more information is borrowed. So essentially what this is saying is that there's more overlap between the covariate distributions in study K and the new patient's covariates, then more information is borrowed from that specific study. So we can take a closer look through an example. Here we have, suppose we have K equals to 2 studies. There's only a single covariate, and we assume that the tau Ks are linear. Near the top of the slide, this is the contribution in the loss function. And I've broken it up into 2 parts. So we can first look at the part with a single asterisk. So here I've highlighted the contributions from the patients on study 1 in green and the patients from study 2 in red. So the idea here is that the contribution from each study, from each patient, is a weighted average of the within study prediction and also the cross study prediction. So M hat 1 is the nuisance function that was estimated using data from study 1. right? So here we're making a within study prediction about a patient in study 1. On the other hand, MHAT2 was estimated using data from study 2, and we're using this estimator to make a prediction about patient in study 1. So here in the dashed rectangle, this represents a cross-study prediction, and vice versa for patients on study 2. So everything is flipped. Now, for the second component with the double asterisk, it's the same idea. Instead of looking at the MHATs, we're now looking at the EHATs. So each person's contribution to the loss function is a weighted average of their within study prediction and a cross study prediction. So this idea, which is called cross study learning, enables information to be borrowed across studies. So the multi-study R-learner's loss function incorporates cross-study learning that links the study-specific treatment effects, tau 1 through tau k, with the nuisance functions through the membership probabilities, PK. Each observation, like I mentioned before, is a weighted average of the within-study prediction and the cross-study predictions. This enables information to be borrowed across studies, and because we're estimating the tau k's and EK's and MK's separately on each study, it directly accounts for the between study heterogeneity in these 3 sources. So in summary, the multi-study R-learner is a class of 3-step estimation procedures. The first step is to estimate the study-specific nuisance functions by a separate analysis of the case studies. Step 2 is to estimate the membership probabilities P1 to PK by a pooled analysis of all the studies. And last but not least, the third step is to estimate the heterogeneous treatment effects tau 1 through tau k using the multi-study R-loss in a pooled analysis of the case studies. So before transitioning to some of the results, I want to pause here and see if there are any questions from the audience.
No, it's very
I
good,
do.
very clearly described. That's excellent. Thank you.
Ellen, I can ask, are we, oh, great. Hey, Cathy, this is Liz Stewart. Thank you so much for this. It's super clear. And as you know, I think Carly and I grappled with this estimand and what is the estimand? Anyway, my question is, your study probability, like your weighting that you're doing of the studies, depends on the X's. Yeah. Presumably in some context, you could imagine wanting to change those. And for example, maybe there's like something somewhat, maybe it's not an individual characteristic, or maybe you sort of just know some other contextual information such that you would want to weight studies a little differently. And maybe as I ask this question, I'm like answering it in my own head. You know, I don't know whether it's time or urban, rural, and maybe the answer is just, well, we would codify that into a variable and we'd include it in the X. But I guess I'm just wondering if you could talk a little bit about, like, are there other scenarios where you could, like, sort of in some sense impose your own study weights if you sort of had some other contextual information where you'd sort of want to upweight, you know, that someone really should get sort of more information from another study. And I think, sorry, one more quick comment. I think what the reason I'm sort of grappling with this a little is right now, your X's are the same for the kind of heterogeneity piece and for this, which probably is what makes sense, but I can just imagine some worlds where there's some other X's that you think are just important contextual things. So anyway, just curious if you've thought about that at all.
Yeah, that's a great question. I think there's definitely a lot of things that can be done through the membership probabilities. With the current setup, we are kind of working under this example of, you know, we have a patient who is kind of, we can think of him or her as a mixture of the case study populations. And I think this, going back to your question, it really depends on what the target population of inference is, right? So I agree that we could definitely work and think about ways to upweight certain studies based on additional covariates, depending on what that target population is. So I think that's something really good to think about. Thank you for that question, Liz.
Cool, thank you.
Any other questions? Okay, awesome, we'll move on. So for the theoretical analysis, there are 2 key results. The first is that under regularity conditions, the multi-study R-learner estimator is asymptotically normal and unbiased. And we can show this in two steps. The first step is that we can show that the difference between L and hat, again, this is the plug-in multi-study R loss, the difference between that and the Oracle multi-study R loss is diminishing at a relatively fast rate as n goes to infinity. With that result, and in addition to point-wise normality result based on series estimation, which is a non-parametric regression technique, we can then show that tau hat is asymptotically normal and unbiased. Now, before I jump into the second result, which is efficiency, I want to quickly introduce a second estimator. So far we've been talking about the multi-study R-learner. Again, this is where the loss function incorporates cross-study learning over the case studies. The second estimator we want to look at is the study-specific R-learner. So this is the case where the loss function is specific to study K. And the way we would obtain this estimate is that we would fit an R-learner to each study separately, and then take the weighted average and ensemble the results. The difference between these two estimators is that the study-specific estimator does not have any crosstalk or information borrowing across the studies because they're treated separately. So the second result is efficiency. So if we let sigma squared denote the conditional variance, error variance, under some regularity conditions in the two-study setting, that for all x's, when the treatment assignment ratios are different, so this is saying E1 times 1 minus E1 is equal to E2 times 1 minus E2 multiplied by some constant C, where C is not equal to 0. And if this error variance is greater than some cut point, then the multi-study R-learner is asymptotically more efficient than the study-specific R-learner. So one thing I want to point out here is that notice that sigma squared can be rewritten as two pieces. The first part is looking at the weighted average of the study-specific error variance, where the weights, again, are the membership probabilities. The second component is looking at the variance of the mean outcome model, M sub S. So this piece is really capturing that between study heterogeneity and the mean outcome model across the different studies. So to that end, we can think of this quantity as a between study heterogeneity transition point, or some threshold beyond which the multi-study R-learner is more efficient. Okay, so now we'll switch gears and look at two different sets of data experiments. So the first is an ovarian cancer simulation. So the setup is that we had 600 observations, and each observation or patient was assigned to one of 4 studies based on a membership probability. We had 40 gene expression covariates that were sampled from the curated ovarian data to reflect realistic and potentially heterogeneous covariate distributions. The two estimators we are comparing are the multi-study R-learner, tau hat, and the study-specific R-learner, tau hat SS. The metric is the mean square error of the new patient HT estimate. So to introduce between study heterogeneity, we generated the tau k's, EKs, and mu k zeros using mixed effects models. So for example, we generated the study-specific tau k's using the following data generating model. Really, the key thing to note here is that we have some random effects eta that have mean 0 and covariance sigma squared tau. The sigma squared tau is a parameter that controls the level between study heterogeneity. So higher levels correspond to higher, more between study heterogeneity in the tau k's. Similarly, we also have 2 additional parameters, sigma squared E and sigma squared mu 0, and increasing those will correspond to more between study heterogeneity in the propensity scores and the baseline risks. Okay, so here are the simulation results. Each panel is characterized by a combination of sigma mu 0, sigma E, and within each panel, moving from left to right, this is really turning up that sigma tau. We looked at two different settings. One is the oracle setting denoted by the solid box plot. So this is where we know the nuisance functions ahead of time. The striped box plots represent the plugin versions where we had to estimate those membership probabilities and nuisance functions from data. In blue is the multi-study R-learner, and the study-specific R-learner is in the peach color. So overall, as between study heterogeneity in these three sources increased, so if we move laterally from left to right, top to bottom, either individually or in combination, so if we go diagonally across, that the multi-study R-learner generally had better performance as between study heterogeneity increased. Another thing I want to highlight is that if we hold the two parameters constant, but we vary sigma E, which is the between study heterogeneity and the treatment assignment probability. So if we move from top to bottom, we'll see that actually the blue striped box plot can sometimes do better, either similarly or better than the solid peach box plot. So what that means is that the plugin multi-study R-learner is more robust to the between study heterogeneity and the treatment propensity, even when we had to estimate the nuisance functions from data. Okay, so for a second data application, this is again looking at the breast cancer example. The goal is to estimate the new patient HTE of neoadjuvant chemotherapy for breast cancer. We had 3 studies from the curated breast data. This is a collection of high quality gene expression data sets. We had 1 randomized controlled trial and 2 observational studies. The outcome is complete pathological complete response to chemotherapy, 1 meaning complete disappearance of the tumor and 0 otherwise. For treatment, we're comparing 2 chemotherapies, A versus T. And we looked at a number of covariates, including clinical covariates, including age, tumor variables related to the tumor status, and also genetic variables, including the oncotype DX gene. So this is a breast cancer screening test that's used by oncologists in practice to determine which treatment to assign to patients, in addition to other genes that were shown to modify the effects of chemotherapy in breast cancer. For this data application, we used a hybrid approach where we had elements that were simulated. And so the reason we wanted to do this is that we cannot observe both the potential outcomes in real data. So we introduced a synthetic treatment effect and generated our tau Ks. We also wanted to have a real data component. So we let both the baseline signal, the MKs, and the propensity scores, EKs, come from real data. So here are the results. When there was little to no between study heterogeneity in the heterogeneous treatment effects, we see that both methods performed similarly. However, as sigma tau increased, the multi-study R-learner generally performed better than the study-specific version. Okay. So in summary, the multi-study R-learner is this flexible framework for HTE estimation. It accounts for between study heterogeneity to help inform treatment decisions for new patients who meet the criteria of multiple studies by estimating their HTE. In comparison to some of the other research and works on multi-study causal inference, it doesn't assume transportability, which in other words, it doesn't assume that the tau Ks are identical or transportable across studies. The second thing I want to highlight is that the multi-study R-learner has this flexibility in terms of algorithmically being able to use these different types of supervised ML or statistical techniques that are appropriate for the task at hand. So it does give the added flexibility of using different approaches for different studies. For potential limitations, the first thing I want to make a note of is that this method requires studies to measure a common set of confounders. This will require potentially some domain expertise or collaboration and data sharing protocols or standardization of data collection to make sure that these studies have the same set of confounders if we're working in the observational setting. And I think with data sets like All of Us, which have standardization of data collection protocols, that this could be a limitation that can be overcome in certain settings. The second potential limitation is that this method assumes that we have access to row-level data for patients from all case studies. And as a result, this is not directly applicable to the federated learning setting where access to row-level data may be restricted due to privacy or data sharing concerns. So at the beginning of the talk, I want to circle back and really think about how the landscape is really ripe for leveraging multiple studies for causal inference. But at the same time, I think it's really important that we proceed with caution and really thoughtfully consider the different levels of between study heterogeneity. And I think the multi-study R-Learner is a method, a stepping stone in that direction. And ultimately, the goal of these methods is really to help the practitioners provide the best personalized care for their patients. So with that, I would like to thank my co-authors and collaborators, Doctors Boyu Ren, Prasad Patil, and Giovanni Parmigiani. This work was supported by NIH grants and also a grant from the National Science Foundation. And with that, I would like to thank everyone on the call today and also for attending in person and be happy to take any questions. Thank you.
Hi, Cathy. Thanks for the amazing talk. Can you just go to the simulation slide?
Yeah.
The simulation result slide. So can you tell me the sample size that you are using?
Yeah.
How many samples you are using here?
Yeah. So we had 4 studies. Each study had 150 samples, so a total of 600.
Okay, if we look at the median of the box plots, and you are plotting the log MAC here, so the MAC is kind of the order of e power 3 or 4. So like, do you have a result of like how this MAC goes to 0, at what rate it goes to 0 as n grows?
Yeah, that's a great question. We didn't really look at kind of the behavior of MSE, but I think that would be something really good to look into. Again, this may be, again, just a reflection of the simulation setup. So I agree that having a more exhaustive look at how some of these estimators behave, especially in the large sample and also different sample sizes, would be interesting to look at. Yeah, thank you for that question.
Thank you.
I have another question, but I don't want to I don't want to dominate, but I'll ask it. Thanks, Cathy. And I love your cartoon at the end because I feel like it's so accurate. Everyone's like, oh, let's combine data without really thinking about it. Anyway, my question is, and I might have missed this, have you thought about sort of uncertainty bounds for this new patient HTE and sort of giving measures of inference and sort of uncertainty for that? And I ask partly because, and it kind of relates to that slide, that comic, and actually relates to this one you just had up, is that sort of if there's a lot of variability across studies, that seems really important for someone to know, because then it sort of feels like there's just then a lot more going on under the hood that we might not be able to be modeling using the X's. And so I guess I'm just curious if you've thought about sort of the implications of the cross-study heterogeneity and then also just the kind of inference for individuals and giving an interval or something like that.
Great point, Liz. Thank you for that. I think one of the things, I guess it's pretty interesting as I was working through this problem is there, with that cross-study learning and using these, different techniques to estimate these different pieces of that loss function, what we choose to kind of go with actually has an impact on the new patient HT, as one would imagine. And so I do agree with you that I think doing a deeper study and looking into ways where these different cross-study learning ML techniques and how that really transpires into, you know, the end product of that tau hat, and kind of coming up with capturing that variability and quantifying that, I think would be really important. And as you mentioned, in practice as well. So thank you for that. That's something definitely a potential next step to look into.
Thank you. I was hoping you'd already solved it, so. Because it's been something bothering me.
Well, maybe I can jump in with a question unless there's someone else wants to. Well, first, an excellent talk. It's a very important, good research and very clearly explained. So thank you for the excellent presentation. I was wondering about some of the efficiency comparison theoretical results that you had. Can you go back to that one? Where you showed in some case you get a strictly better variance asymptotically. I was just curious, are there cases where is one always greater or equal to the other, even without this assumption about the propensity scores? Or are there cases where the separately analyzed data sets first, where that can be better?
Yeah, thank you for that question, Michael. So in this case, we were looking at a two-study setting for this analytical result. So for this one, it does require that very, I would say, pretty specific constraint where we have to have these, you know, different either randomization ratios or probabilities of treatment assignment ratios to be different in this specific way. I think one really good thing as a next step is to look at more studies and relaxing some of these conditions. And we may do this through simulations. And yeah, I think the short answer is for this one, we specifically had to require that the difference in the propensity scores. Yeah.
And that makes sense. And what happens if C is 1? Do you have exactly the same propensity scores in both? Then
there's no efficiency gain in that case. Yeah.
Is it the same efficiency? I guess my question is there ever efficiency loss? Is that possible?
Yeah, I think that is plausible. I will have to double check because I don't want to misspeak here. But I definitely think there are cases where the multi-cellular learner may lead to efficiency loss in certain parameter spaces. Yeah.
Okay, thanks. That's great.
Well, if there are no other questions, thank you guys so much. And thank you so much, Cathy, for this great presentation.
Thank you.
Yeah, very well.